To the, I think, 15th annual policy forum. Well, he can come up if he wants. I appreciate all of you getting up early and coming to the policy forum at 8 a.m., even though we don't have breakfast for you. and today we're going to actually, I think for the first time in I don't know how long, actually have good news from the Hill. So I'm really looking forward to Ed's presentation. After that, we're going to be, we'll have a panel that'll be talking about the state level responses to opiate use. So I think we have a terrific lineup today, and I'm really looking forward to hearing the talks myself. So to kick us off, I'd like to introduce Charles O'Keefe. He's going to come up and talk about Friends of NIDA. So Charles.
Thanks very much. About 15 years ago, the former director of NIDA, Alan Leshner, and his deputy, Tim Condon, suggested to some folks at CPDD that the Friends of NIDA should probably exist. Most NIH agencies have a group called Friends of, and the reason for Friends of whatever the organization, is that in the case of NIDA, NIDA has a number of things that they can't do. Among them, they can't go and present themselves on the Hill to ask for anything. The administration has to approve anybody that goes to the Hill, and they can't go on their own if there's a position. And that's fairly crippling. The other thing they can't do is they can't spend any money outside of the regulations of grants and a whole batch of complicated stuff. So they can't just sort of see something important that they believe needs to be supported. They can't spend any money on it. So Friends of NIDA was in fact established about 15 years ago. And the first meeting had about 10 people, and Nora Volkov by that time was the director, and she and Tim participated. Friends of NIDA is a group of organizations ranging from the American Psychological Association to all of the organizations involved in treating patients, all the organizations involved in policy, smaller organizations, so it's basically a consortium of organizations. And the responsibility that they take on, the Friends of NIDA takes on, is to do those things that NIDA can't do by legislation or by policy. One of the things that Friends of NIDA does is holds briefings. We hold several a year, and those briefings typically are composed of the director of NIDA, a researcher, typically from CPDD, and a patient who has benefited from the research of that particular investigator. And the reason for having these briefings is to show members of Congress and their staff the importance of funding for NIDA. Most of the staff don't understand what NIDA does. Most of the organizations that lobby on Capitol Hill are people with big constituencies. There's not a good constituency for addicted patients. Nobody really wants to listen to a group of addicts coming into the office. And consequently, there's no real incentive to move forward with funding for NIDA, and that hurts your bottom line. So that's one of the things that Friends of NIDA does. The other thing that Friends of NIDA does is NIDA needs to attempt to bring in the best and brightest of young scientists for training to encourage them to come into the field. Each year, the Intel Science Fair is held. It's a very competitive whatever you call it, science fair. Thousands of high school kids compete to get involved in it, and they are chosen, and then at that science fair, typically we will ask one or two or more members of CPDD to go in and judge the science fair and find the best of the presentations related to addiction. And Friends of NIDA, because NIDA can't do anything about these folks, NIDA can bring them into NIDA and meet with them and take them over to NIH campus, but they can't give them any funding. So Friends of NIDA actually gives an award each year to the first three winners of the Intel Science Fair, which are related to addiction. So the other most important thing we have to do is our education efforts on the Hill are to be sure that Congress is aware of the work that's being done and make them aware of the need for additional funding. Fortunately, this year we've been successful. Ed's been successful. Sandy's been successful. And it's been a good year. Friends of NIDA has no staff, no salary, no expenditures other than those things. We pay for the briefings on the Hill, we pay for the science fair winners, and we've been supported by a few organizations, many of them small, but most of our funding comes from you. Individual members of CPDD, each year or two, once or twice, not twice a year, once every year or two, we send out a mass mailing. We sent one this year. We got a sufficient amount of money coming in. When you get one of those ultimately letters saying, hey, you need to support Friends of NIDA, I hope that you will seriously consider it. It's the only funding that we have. So I'm just up here sort of begging for you to support Friends of NIDA. It's an important organization. It's actually it was created by CPDD. It is primarily supported by CPDD. All of the efforts and the congressional briefings that Sandy, I think, is going to talk about. No. Okay. Ed's going to talk about. All the visits on the Hill where we invite members from CPDD to visit congressional offices. All of these things are incredibly important, and they're only supported by you guys. So this is basically a CPDD individual members organization. So when you get a mailing, send us some money.
Thank you, Charles. So the next talk will be by Ed Long, who is with, is it still Van Scoyoc?
Still Van Scoyoc.
Yeah, with Van Scoyoc and Associates. And he's going to be giving us a report from the Hill. And for once, it's good news. So Ed, take it away.
Thanks, Martin, and thank you, Charles, and thank you, Sandy. But I do want to say before I start my, there it is. Somebody know how this works? Presentation that the Friends of NIDA wouldn't be so successful if it wasn't for the work of Charles, Bill Dewey, who is not here today, and Jeff Mumford of the American Psychological Association, who's lent the offices of APA, and also I think they've underwritten most of the briefings. So talking about unpaid but highly skilled labor, they've been the organizational glue that's made the Friends of NIDA so successful. I'm here to talk about what I call drugs, public health, politics, and research. Oh, there it is. So my first one, as it's been referred to, there's some success that we have for fiscal 2018. But show me the money, NIH, NIDA funding, fiscal 2018. Just to get a little sense is, Congress has federal government has fiscal years that don't necessarily totally correspond to calendar years. Our fiscal year for 18, which we're currently starts October 1st of 2017 and ends September 30th of 2018. Congress, for a variety of reasons, didn't actually complete its 2018 appropriations bill until late March 28th of this year. So the results have only recently just come in, and the money has not even been close to being spent. So let me just start out a little bit where we started from in terms of fiscal 2018 budget. You know, I'm a political science major, not a scientist. I'm not quite sure why they call it science, because there's no science dictating the way Congress and the administration behaves, particularly in this administration. I think Dennis Rodman is the science advisor for the president here. But I do hope that the Canadians don't bother to burn the White House again. It's just awful the first time. The president's budget, just so you know, when it came in early 2018, had a total request for NIH of $26.9 billion. And that compared to the 2017 appropriation of 34.3. And I know that all of you who have been involved, those of you who have been involved in advocacy for research, it was quite a startling budget, given that it proposed about a 21% cut to NIH. We were going, the budget for, at least for NIDA, was going back to pre-doubling era in terms of funding levels. For NIDA, the budget was just as bad. Request was $865 million. NIDA's appropriation for 17 was $1.09 billion. That's a $225 million reduction, or a 20.6% cut. I want to give you a context because the final results will be much more pronounced and dramatic. But in the interim, CPDD and the Friends of NIDA did their advocacy. Actually, we've consistently been advocating for more funding for NIDA in addition to funding for NIH. And to refer to what Charles was saying, we can do what NIDA can't do. We can actually advocate for more money for NIDA than what's in the president's budget. We can coordinate, we can meet with key congressional staff, key members of the appropriation or funding committees, and that's something that we did. And thanks to Sandy's, Dr. Comer's leadership, we had our second CPDD Advocacy Day on February 28th. We had 16 attendees, we had 34 meetings with congressional staff, and we in the Office of Van Scoyk Associates followed up with many of those congressional staff to sort of provide background material and information on our agenda. And our agenda was a $2 billion increase for NIH over the 17 appropriation level, not over the president's request, a significant increase for NIH's opioid research, and targeted opioid funding for NIDA. Just a little background. Congress, as you know, has passed lots of legislation wrapped up in CARA, which I can't remember what the acronym is right now, last year. A lot of authorizations of activities that should be done, but not any funding for research. We've been consistently saying if you're going to tackle the opioid crisis, it's not just about treatment, you've got to put more money for research. Well, we ramped that up and doubled down in that period. So what happened? Some significant changes from the earlier slide about what was in the president's budget. NIH overall for 2018 got a $3 billion increase to $37.3 billion. That's on top of 2 years of $2 billion increases. So over 3 years, from 16, 17, 18, NIH has received a $7 billion increase, which doesn't totally stem the sort of flatlining after the doubling, but it's a significant boost of funding compared to where things were. So that's about a $10 billion swing from what was in the president's budget proposal. That's a lot of money. For NIDA, it's even more dramatic. NIDA's budget increased by $292.7 million. Usually we're content, or not content, but we're reasonably happy if we get a $40 million or $30 million increase. We got the largest increase of any institute at NIH at 26.7%. $250 million of that increase is for opioids, and I'll get into that, how disposition of that money later. But the overall increase in the line item for NIDA is $518 million. That compared to an $865 million request from the president. I like this slide. These are the institutes by percentage increases in the 2018 budget. And you notice that NIDA got the largest percentage increase. Again, that includes the opioid money. The second institute was National Institute on Aging, and the bulk of that increase is for Alzheimer's. Third is NINDS, goes NINS, or Neurology Institute, also got $250 million for opioid, largely for developing non-opioid pain alternatives. And the Office of Director is the last one. Now, in terms of this is just a slide about increases for NIH, and over the last couple of years, pretty much NIDA and NIH have been flatlined, but you can see from 16, 17, 18, there is a jump in funding both for NIH and for NIDA. We do have some challenges, though, going forward. This slide shows success rates. That's basically number of approved RPGs versus the number of reviewed research project grants compared to the number of approved. As you can see, there's been a dramatic decline from 32% during the midst of the doubling down to about 19%. The bulk of it is, I've looked at the numbers, is that the number of grants have been pretty reasonably stable. The denominator has increased dramatically in terms of the number of submissions. And the other interesting fact from looking at the numbers, the size of NIH grants have more than doubled from over that period, largely accounting for inflation. But still, it's that much tougher, particularly for young investigators, to get money when you have a success rate of below 20%. That's also for NIDA. Now, this is talking about challenges. I'm not going to dismiss the importance of getting a $7 billion increase over the last 3 years, but when compared to the baseline, that is NIDA's budget, NIH's budget based on constant 1995 dollars, we still have a long way to go. The top line is appropriations. That last line in red is the president's budget, which looks like it's a $3 billion reduction from the 18 appropriated level, but you still see an increase. But the bottom shows NIH appropriations in constant dollars, and you can see in terms of actual spending power, NIH for biomedical research is less than the number in 2003, which was the end of the doubling. So we still have challenges, we still have budgetary needs, and we still have work to do, which gets to the next slide of what are Friends of NIDA and CPDD's requests for fiscal 19, which is Congress is working on these bills right now. For NIH, we're seeking a $2 billion increase to bring it up to 39.3. As you can see, the president's request was just around the fiscal 17 level. And for NIDA, our goal is to keep that $250 million for opioids as part of NIDA's base funding. So we're looking at, and the president's budget did not include that money as base funding. So we're looking at $1.383 billion plus an increase proportionate to the overall increase for NIH. This is a little budgetary point. By trying to wrap up that opioid money into NIDA's base, the $250 million for 18 becomes $500 million over 2 years. So you can see how if you can add something, a big chunk of money like that to the base, it compounds itself. So it's a lot more money than just the $250 million. And 250, half $1 billion, that's some real money. Now, opioids. Obviously, not just for your research, for the public health crisis, but for Congress, opioids is a very big deal. And it has both a public health dimension and a political dimension. And I think that, and I want to emphasize, sort of underscore, like marijuana, for different reasons, marijuana has its own political spin, opioids does as well. And thus, you're seeing Congress, when you have a convergence of a public health crisis and a political push, then Congress actually does act. In some cases, Congress overreacts, but nevertheless, it does act. And our objective has been, if Congress is going to act, and it's going to be talking about providing money, let's make sure NIH and NIDA gets a good chunk of that change. So obviously, these are numbers you've already seen. Drug overdose deaths, more than motor vehicles, more than injured by firearms, more than homicides, more than AIDS, and about 67% of drug overdose death is opioid related. Other opioid facts, and this is the interesting thing, if you want to look at states that have the highest age-adjusted deaths, West Virginia is the highest, Ohio, New Hampshire, DC, and Pennsylvania. And when I mentioned that there's a political undercurrent to some of this, West Virginia, very important. There's two senators from West Virginia, Joe Manchin and Shelley Moore Capito, who are sitting on the Labor Age Health Funding Appropriations Subcommittee that funds NIH. Also, Senator Manchin is up for re-election in West Virginia. That's a very big state that the Republicans are trying to pick up. I don't need to tell you that Trump won West Virginia by 40 points, and Joe Manchin is about the only Democrat who can win in that state. That's a long way off from when Robert C. Byrd was senator from West Virginia. Ohio, another key battleground state. Sherrod Brown, Democrat up, and also, as anybody knows, that it's always a tough election. New Hampshire, that's the first primary in the country. New Hampshire, District of Columbia, we don't vote, so it doesn't matter. Pennsylvania, another key state. President Trump won Pennsylvania in 2016. Pennsylvania it's a working class state. Pennsylvania is going to be another key state in 2020. And Bob Casey, Democrat, is up in Pennsylvania, again, another battleground state. Also, in terms of the statistics of 345% increase in opioid-related deaths, and here's the interesting thing, is a 5-fold increase in overdose deaths involving synthetic opioids. And since 2013, that's since 2013. In 2016 alone, there were 20,000 deaths related to synthetic opioids, mostly synthetic fentanyl, and that is one of the other pushes for congressional legislation. Federal response, and I'll just quite quickly go through this. One of the reasons why there was more money in 2018 is that Congress struck a 2-year budget deal in early March that had a $300 billion increase, increases for defense and non-defense. Our funding, NIH funding, falls within the non-defense category. And implicit in that agreement was a $6 billion increase for opioids and mental health over fiscal 18 and 19. And the president's budget announced in February proposed $3 billion. And the president, thanks to the opioid commission, which Bertrand Madras sat on, was chaired by Chris Christie, former governor of New Jersey, and a part of the recommendations was increased funding. There was $3 billion for the Department of Health and Human Services and a significant increase in NIH's research on opioids. A little bit of specifics in terms of the omnibus spending bill had $4.6 billion for opioids, and within HHS, there was $1.5 billion for state opioid response grants. Those are largely grants distributed to the states in terms of a block grant to be in turn competed within each state. $350 million for Centers for Disease Control and Prevention, and $500 million, as I referred to earlier, in additional funding for NIH. The money in NIH, just to get drilled down a little bit deeper, it's targeted for research on opioids and non-opioid alternatives. It's divided evenly. It's not allocated to the Office of Director, as we thought it might. It's allocated evenly between NIDA and NINS, $250 million to each. It's two-year money. Most NIH money has to be obligated, if not drawn down, by the end of the fiscal year. Given that it was so late in the fiscal year, Congress gave an additional year for NIH to spend it, so that money has to be obligated by September 30th, 2019. Very important data point because OMB still has not approved the overall allocation of these funds, and also gives the NIH director authority to transfer any of those funds to other NIH institutes to fund their opioid-related research. So what that means is the 500 is given to NINS and NIDA, but NIDA will not get all of that 250. Some of that money will be distributed to other institutes based on, in a competitive basis, based on a decision by the NIH director, Dr. Francis Collins. How much of that 250 is yet to be determined. I assume it's going to be somewhere over 200, but we shall see. Congress, as I mentioned earlier, is passing a lot of opioid bills. I think that the Republican House realized the tax cut did not really resonate very much, except for some of the biggest beneficiaries and all those people in Wisconsin who could buy Costco cards with their tax savings. So Congress has decided they want to be active on by passing a number of opioid bills. Most important for us, that's important, but for you, the funding level is so much more important because that's where the rubber hits the road. The other issues we've been dealing with, is Congress and synthetic compounds. Long story short, how much time do we have? Martin, you want 10 minutes? Okay. Right now, the DEA has said they do not have the authority to schedule synthetic compounds in as expeditious a fashion as required to respond to the increased import of synthetic fentanyl and other compounds that are either imported or shipped into the United States or shipped through Mexico. And as a result, what Congress has been responding is by granting or passing legislation that either attempts to legislate to schedule compounds specifically by legislating, or by giving DEA the authority to schedule on a temporary basis a broad category of synthetic compounds that are substantially similar to existing already scheduled either Schedule 1, 2, 3, 4, or 5 compounds. And the actual legislation, what's called the Stop Importation and Traffic of Synthetic Analogs Act, is actually coming to the House floor this afternoon. What they want to do is create a new Schedule A where they can essentially put synthetic compounds into that category, which will allow DEA to prosecute, restrict importation of those compounds. Now, admittedly, given those numbers in terms of the 20,000 deaths, it is a public health issue. Our concern is that when you put some of these compounds into Schedule A, are they being treated as Schedule 1 compounds, which therefore restrict and make it much more difficult to conduct research? Fentanyl is a Schedule 2 compound. Synthetic fentanyl would be potentially treated as a Schedule 1 compound and therefore restrict research on that compound. What we've been trying to do is create some sort of a streamlining licensing and protocol review requirements, because as you know, Scheduling 1 requirements are very restrictive. Many of your labs, you have one scientist with a Schedule 1 license. Not all of your scientists have Schedule 1 licenses. There's obviously restrictions in terms of safe, location, where you can move the compounds, and also it can be a very onerous, lengthy process to get a Schedule 1 license. So we've been working with Energy and Commerce Committee and to basically provoke or prompt an interagency conversation between DEA, HHS, and its affiliated agencies, NIH, NIDA, and FDA, on injecting and enhancing HHS's role in reviewing both the process of scheduling compounds and ensuring that at least researchers with a Schedule 2 license can be treated as researchers with Schedule 1 licenses for the purpose of conducting research on this new category of compounds, of synthetic compounds. And so far, we're making progress on that, but it has been a lengthy process. I can say that we are somewhat restricted or disadvantaged in that we obviously have a Attorney General who's very tough on a variety of heretofore illegal or scheduled substances, including marijuana. We also have Congress, who rightly so want to respond to this public health crisis. We just want to make sure that the research community can, while dealing with the issue of diversion and with sufficient controls on that issue, can still conduct research, because either these compounds potentially have therapeutic value, but we also need to develop antidotes, because some of these synthetic fentanyls are stronger than the current versions of naloxone that are available, and we need to do the research to make sure that we can enhance the naloxone and other antidotes so that people are not dying on the street as a result of using these synthetic compounds. The other issue I want to talk about is marijuana, and this is where actually the politics are a little different than on opioids, and where, as you can tell, in addition to what's going on at a state level, there's been a lot of proposed activity, that is legislation introduced, from a variety of interesting sources, bipartisan in nature, to actually not necessarily move marijuana into Schedule 2, although both marijuana and CBD are still Schedule 1, but create a new category. Sounds familiar in terms of synthetic compounds, a new alternative schedule. It's an interim schedule, like we Catholics called it limbo, but anyway, somewhere in between, but also whereby there would be less cumbersome registration requirements to enable more research. So you have Dr. Andy Harris, very conservative Republican from the Eastern Shore of Maryland. He's an anesthesiologist from Hopkins, working with Earl Blumenauer, who heads the Bicycle Caucus. He's from Portland, so very different individuals working on the House side. Orrin Hatch, who actually, when I came to Congress, was considered an extreme conservative. He looks very moderate now compared to some of his other colleagues in the Republican caucus. Has a bill called the MEDS Act. There's a CBD Research Expansion Act with Chuck Grassley, no raging liberal, who's chair of the Judiciary Committee with Dianne Feinstein. And our focus has not been on decriminalization, not been on legalization. It's been on research expansion in all of this discussion. Lastly, and I just want to point out as a cautionary note that in some cases, I always say Congress responds to public imperatives and internal political needs, and doesn't necessarily respond to science. Either in the case of Attorney General Sessions, who has a very strict view on marijuana. I think he was quoted as one time saying he used to like the Klan until he realized they smoked pot. And I don't think that's a I don't think that's created. I had to Google search. I think he really did say that. To now, we have on the flip side, we have Schumer, not Amy Schumer, but Senate Minority Leader Chuck Schumer, saying he's going to introduce a bill to decriminalize marijuana. And we also have various Democratic presidential candidates. I'm not sure half the Senate, there are at least half the Democrats in the Senate. Booker of New Jersey has introduced the Marijuana Justice Act to legalize marijuana and expunge convictions for marijuana use or possession. And he's been joined by potential Democratic presidential candidates. Sanders, Gillibrand, and Jamila Harris have endorsed Booker's legislation. Clearly, Democrats think that marijuana legalization is the key to the millennial vote. Regardless of what that impact might have on adolescents, which is still being researched by the ABCD study that's being sort of led by NIDA, but they're not letting science get in the way of their political imperatives. We shall see whether that goes any further, but it's interesting that the increase, and also if you looked at some of the Democratic primaries in Pennsylvania, a lot of those congressional candidates campaigned on decriminalizing or legalizing marijuana. So that's something that we should note, given I think they're getting a little ahead of themselves in terms of changing the laws without understanding what the impact on behavior is, and that's where, once again, NIDA and your research should come to play.
Hi, everyone. I want to thank you for coming this morning to this session. I think it's very important. And I would like to echo Ed's sentiments of thanks to both Charles O'Keefe and Bill Dewey from the Friends of NIDA. They've donated a tremendous amount of time and energy to moving things forward for all of us in our organization and the field in general. So I'd like to thank them and give them a big hand of applause. Equally important, I think, is the work that Ed Long and Katie Van Landingham have been doing at Van Scoyoc. They are incredibly plugged into the people on Capitol Hill, and they organize the meetings with those members and with members of our organization, and it's tremendously important. And I think we're starting to see some fruits of our labors here, actually, with this increase in the budget for NIDA. Again, I would like to thank Martin Iguchi for his tireless efforts in putting together this forum. And so he's put together a nice series of speakers to talk about state-level responses to the opioid epidemic. And the first speaker is Martin Iguchi.
Well, good morning. And so I just thought I'd give a quick visual on the current availability of MAT across the country. And I think that just having a visualization here for you will be somewhat enlightening. So let's, where are the slide? Here, okay, yeah. So in this slide here, I've put the waivered 130 buprenorphine providers. There's 65,000 waivered providers. I put the addresses of every one of them, essentially, by county. And you can see that in terms of where the buprenorphine providers are, it's clustered fairly heavily in all of the urban areas in the country. The darker patches here are suburban areas, and the lighter patches here are rural areas. And you can't really see the very darker colors because that's where all the urban areas are. So essentially, the overlap between the providers and urban areas is pretty complete. you have a distribution of providers in suburban areas, but in the rural areas, you have virtually no coverage whatsoever. So about a third of the country has no MAT providers at all, because the methadone providers are all in the urban areas. They completely overlap with these dark red dots here. So how do you get more providers in these light areas where we have absolutely nobody providing buprenorphine or methadone? So just to enhance that perspective, I've provided a darkened view of all the counties with no registered providers. Now, what I've done here is I've put together a slide that puts together the overdoses, opiate overdoses for 2015, with the availability of providers. And so the really dark red areas are areas that have a upper third tercile of overdoses per 100,000 with no providers. And there's a series of purple dots here that you can't see, and I apologize for that, but the purple dots are actually right in this area as well, and those would be the counties that have the higher tercile of overdoses per provider. Now, in some ways, just having this picture by itself, it does give you an idea of sort of the hot spots then that counties might be looking at. Now, I'm going to blow this up for you a little bit by showing it at the state level. Here we have counties that have a high percentage of being in the top tercile of overdoses in the country, but a lack of providers in North Carolina, in Kentucky, and again, it's the red and purple counties here. Ohio, you can see the cluster down here. West Virginia, and you've heard these counties named before. And finally in Tennessee. So just by laying out this kind of a graphic, I think it gives you an idea of where to begin to focus, where to try to bring more resources to. And we actually have plotted out this kind of map for every state in the union, and we'll be updating these to more recent overdose data in the near future. Now, the problem, of course, with this kind of mapping is that our systems of reporting overdoses and reporting on the availability of resources are lag behind reality by about a year, 2 or 3. In fact, as I'm showing you here, 2015 data, the 2016 data just came out not too long ago, and so the updates would show actually a little bit of a shift in the overdose deaths, because as fentanyl began to really enter the market around 2016, it really did shift the profile of some of these maps. But it doesn't change the lack of availability of providers. And so where we are seeing deaths, of course, are in a lot of these rural areas where there is no real response. Further, when I'm plotting for you the 65,000, I had plotted for you the 65,000 buprenorphine providers, but a huge portion of them actually don't provide any treatment at all. They have a waiver, but they don't actually provide treatment. And further, those who have the ability to treat up to 30 or 100 or 225 individuals, it doesn't mean that they necessarily max out on that number. Now, the barriers to providing care in these areas are numerous, and I think that what we wanted to talk about today is how can we overcome some of these barriers? How can we help physicians to decide to treat our patients, then to remove some of the stigma, remove some of the fears of treating these individuals? How can we support physicians in their efforts so that we can bring more treatment to areas where we have no treatment? And that's really the focus of our talk today. And so I'm hoping that our next two speakers will be much more enlightening than my just providing you the problem. So why don't we go on to the next speakers? Thank you. Oops.
So our next speaker is Dr. Todd Corthues from Oregon Health Sciences University, and he'll talk about state-level innovations in response to the opioid overdose crisis. And while he's coming up on stage, I just want to take the opportunity to ask you to encourage everyone to consider coming to Advocacy Day next year. It's a really great experience. It's really important that we do this, and you should be receiving a message through the app. So if you're interested, please send me an email.
All right, well, thank you so much for the invitation. These are my disclosures, no financial conflicts of interest, but I do receive donated study medication from a couple of companies. So to address directly the need for models that bring together the ability to expand MAT access in primary care is a complex task. We know that primary care is well suited for integrating treatment of chronic complex diseases. We've done this for diabetes, we've done this for heart disease. Why not do this for opioid use disorder? We also know that integrating medications for addiction treatment into primary care can expand access to the opioid use disorder treatment. But few prescribe, and as Martin just pointed out, there's great disparities around the country in who is prescribing. And consequently, AHRQ in 2016 commissioned a scoping review to identify promising models for optimizing treatment integration. We solicited key informant interviews from 11 experts in the field in an interdisciplinary fashion. Many of you are in the room. Thank you so much for your service here. We also conducted a systematic review of 5,892 abstracts, 475 full-text articles, and that identified 27 papers that inform models of integrated treatment of MAT and primary care, in addition to some gray literature and unpublished work. Key informants identified 4 domains that these integrated models all seem to have at least some component of. There is a pharmacotherapy model, typically with buprenorphine, sometimes with naltrexone. There is a provider and community education and outreach component that's typically required. For example, Data 2000 waiver trainings, and a coordination of care component that integrates medical and psychological needs with treatment of opioid use disorder. And then finally, psychosocial services. And I should point out that all of this was recently published together with Dr. McCarty and Roger Chow and others in Annals of Internal Medicine recently. We identified 12 representative models for integrating care. I'm going to address OBOT, office-based buprenorphine treatment, as a practice-based prototype because it's so related to many of the efforts that the states are promoting in systems-based models. And I'll focus on the ones most pertinent to primary care. So to start off, office-based opioid treatment, or OBOT, is a practice-based model of care. It typically involves buprenorphine naloxone that's prescribed during a typical office visit for primary care. There's often a coordination component where someone in the practice, a nurse, a medical assistant, maybe a counselor, is the glue person for tracking patients and holding the procedures together. There's an educational and outreach component in that all prescribers have to undergo Data 2000 waiver training to prescribe. They also have access to the PCSS system that I'll describe in a minute. And then Data 2000 requires some access to psychosocial support, either through brief on-site counseling by the provider themselves or someone else on staff, or access to psychosocial services in the community. In 2017, the big news was the expansion of Data 2000 waiver training to nurse practitioners and physician assistants who provide the bulk of primary care in rural America, those treatment deserts that Martin was pointing out. The funding mechanism for this from a policy standpoint so far has typically been provider reimbursements for billable visits. I want to give a nod here to the provider clinical support system that's funded through SAMHSA, through a grant to American Academy of Addiction Psychiatry and ACIM. This offers general information for clinicians in primary care practices in evidence-based treatments for opioid use disorder. It links primary care providers who sign up for the service with a national network of mentors who have expertise in MAT and addiction management. And this approach allows mentors and mentees to build a relationship over time. Basically, people have my cell phone number and they call up and say, hey, I've got this patient. What do you think? And we talk it through. This is a free service through the SAMHSA grant. We'll hear more about hub and spoke models in a minute, so I'll just gloss over this. But this model was initially rolled out in Vermont, and a very, very exciting innovation. It primarily uses buprenorphine and naloxone, although there's some expansion of that. It relies heavily on the care coordination and integration component, where hubs are centers of expertise that link with smaller primary care practices, et cetera, in more rural areas as the spokes. There's typically a nurse case manager and or care connector of some level of training, such as a peer or a behavioral health specialist, for example, who helps coordinate care. And then there's a lot of community outreach that we'll hear about in a minute, and education to increase prescribing of buprenorphine. Psychosocial services are typically embedded within the spoke site, but also they get a lot of support from hubs. And there's this back and forth. When patients aren't doing well in the spokes, they can refer back to the hubs and vice versa. And this has been funded by CMS State Medicaid waiver, initially to Vermont and other places. Along with, my understanding is a lot of legislative support from the Vermont legislature. Okay, and the bottom line is there's been a marked increase in treatment engagement with the Vermont hub and spoke model. I'll talk about a variant of hub and spoke, a virtual hub and spoke that's Project Echo, again relying primarily on buprenorphine, naloxone. And this is a telementoring system where, at least in New Mexico, where this was developed, there are nurse practitioners or physician assistants who are performing most of the care in rural communities. At the time New Mexico developed this, they didn't actually have prescribing capacity, so they were linking with prescribers as well. And these primary care docs personnel, they evaluate and screen the patients and monitor, et cetera. And then through typically weekly tele-mentoring sessions, they discuss the cases and get advice on how to move forward in patient management. All ECHO team members provide counseling and behavioral therapy and whatnot advice. I'll just briefly describe how this is rolled out in Oregon, where I'm from. We have a weekly MAT ECHO program. It lasts typically for 12 to 16 weeks, depending on holidays and whatnot. The primary care providers, we cap at typically 25 per time. We always have a waiting list. there's a case presentation so the primary care doc presents their case. Hey, I had this patient come in this last week. What do you think? And then there's an interdisciplinary panel discussion that includes addiction physicians, counselors, peers who are in recovery who are giving their take on treatment, and an addiction psychiatrist. And we're funding this currently through the State Targeted Response, STR, expansion, as are several other states. Another model is the collaborative opioid prescribing model developed in Maryland. This was also through a Medicaid waiver program where the state of Maryland focused on the problem in Baltimore, built somewhat of a hub and spoke model where drug treatment programs, particularly OTPs, were the center, and are the first point of care for prescribing and whatnot. And then patients transition to primary care from there in FQHCs in the city. There's counselors that are performing outreach to community physicians to make them aware of this, and a lot of psychosocial support at the opioid treatment program. There's also the nurse case manager model called the Massachusetts model, where they've really innovated with this. Again, starting off mainly with buprenorphine. This model is interesting. It takes a lot of the responsibility for the whole program out of the hands of the physician and puts it squarely with a nurse case manager who does the initial screenings with patients, contacts patients, and partners with the rest of the treatment staff around prescribing to get people into care. There's a large educational and outreach component where there are a lot of community trainings, physician training programs. Some of you in this room, thank you for what you're doing in Massachusetts, are on the road all the time in smaller counties in Massachusetts doing this. And they've operationalized the nurse care manager training with an initial 8-hour training session to scale this up broadly throughout the state. There are integrated counseling services typically on site or nearby. And this, again, was funded through state Medicaid in Massachusetts, who reimburses FQHC nurse care manager visits. And that's a very unique model that other states might consider. And then building on Gail D'Onofrio's work in New Haven, a newer model is linking patients who come in with overdose or opioid use disorder in emergency department settings after initiating them in the ER with buprenorphine, linking them to primary care afterward. And this requires a fair amount of coordination with the OBOT providers in the community. Education and training, there's not a huge training requirement for this model. And psychosocial services are typically whatever is available through medical management and primary care. And so far it's been funded from a NIDA grant and patient insurance, although there's some updates on that. Inpatient initiation of MAT is another exciting model. Inpatient hospitalization is an overlooked opportunity for engaging people with opioid use disorder whose illness frequently lands them in the hospital where historically it's gone unaddressed. And so at least 4 centers around the country in Boston and Minneapolis and Portland and a few others are forming these inpatient addiction medicine consult services where MAT is started during the hospitalization. You come in with your endocarditis, and a counselor comes and says, hey, are you interested in treatment? And a doc comes in and begins prescribing immediately during the hospitalization, and then transitions the patient to care immediately upon discharge. So far, this has been funded through hospital support. This is a hole in the policy system. We need better funding for these activities. This is how it plays out in Oregon. We have an interprofessional team of an addiction medicine physician, counselor, peer mentors who are crucial. They're really the key to this, who've changed inpatient hospital culture. And then we have rapid access to community treatment through an in-reach coordinator. This is someone from an OTP who comes in and actually does the OTP assessment while the patient is still hospitalized, so they dose the same day they leave. There's no gap in treatment. And then finally, accountable care organizations and partnerships with communities. This model has been playing out in Southern Oregon, where the ACOs, called CCOs in Oregon, really partner with community stakeholders to do a lot of education and outreach. And they get community buy-in with primary care providers, with local law enforcement, with faith communities, many perspectives, and come up with a community treatment plan for typically expanding buprenorphine naloxone. Because the ACOs are involved, they can do a lot in terms of reducing the prescribing burden, decreasing prior authorizations, for example. And this is a great model for states that adopted Medicaid expansion. Some emerging models that are still just newly coming out. The Virginia Addiction and Recovery Treatment Services, or ARTS program, was just started in 2017, and it directly increases Medicaid payments for addiction treatment providers and service expansion. If your organization is offering buprenorphine, you get a little more Medicaid reimbursement for that. And that's already, just in the first 9 months of the program, increased by 60% the people receiving MAT services in Virginia. Which is a remarkable policy success. There's the Baltimore Levels of Care program, which takes Gail D'Onofrio's work in the EDs and creates wraparound services in Baltimore emergency departments, all 11 of them, to do MAT on demand, naloxone rescue kits, and referral for services. And then we've also heard about the state targeted response, or STR, and it'll be interesting to hear how this plays out in future policy forums. These were massive block grants to all of the states that are 2 years to directly fund expansion of treatment services, and we'll be learning more about that down the road. And then very recently this year, there's been the Rural Opioids Initiative. And this is just a single summary slide shared by Rich Jenkins at the NIH. This is a cooperative agreement between NIDA, the CDC, and the Appalachian Regional Commission, the goal of which is to expand opioid use disorder treatment and overdose prevention in the very counties that Martin was pointing out earlier are some of the highest need and biggest treatment deserts. We're doing respondent-driven sampling in these counties to really reach into unreached populations of people who are using opioids and try and figure out what models are going to work best in those settings. So much more to follow there. The ideal model of care for a specific setting varies depending on available expertise, population demographics, proximity to centers of excellence, which is an issue in rural areas, and reimbursement policies. Most models use non-physician coordinators, and I think this is an important thing to emphasize, particularly when I speak with medical audiences. It's not all about the doc. In fact, it works best typically when other people are coordinating it. The models often are combined and tiered. They're not mutually exclusive based on local resources. Last slide, directions for further research that were identified in the systematic review. There are big areas of uncertainty around quality measurement methods for MAT in primary care, clinical assessment tools to individualize care, who's going to do better on buprenorphine, for example, versus naltrexone and other treatments, optimizing psychosocial components of MAT, cost and cost effectiveness of various treatment models, and optimal methods of care coordination and integration of care. We also need clinical effectiveness trials or assessments anyway, looking at things like cash carry practices, comparing the effectiveness of different models, and particularly newer MAT, the long-acting injectable buprenorphine and naltrexone and other things on the horizon. And then evaluations of telehealth and telemedicine approaches, which appear to be particularly promising for rural areas. And I'll stop there. Thank you.
So we're going to hold questions until the end, and so hopefully you'll have lots of, there'll be a lot of discussion after the last speaker, who is Barbara Simaglio. I'd like to welcome her. This is her first meeting at CPDD. We had a little discussion before the symposium, and she said that she thought it was interesting that there's such a big disconnect between what researchers are doing and what people on the ground are actually doing. So hopefully she'll bring that a little bit closer together.
Do I push to advance the slides? Oh, green button. Okay, great. Good morning, everyone. Oh, okay. Just getting oriented here to how these things work. Thank you, Martin, and thank you for inviting me to this meeting. I am not normally with this group. I'm former state director of the Alcohol and Drug Program in Vermont, and prior to that, I worked in the state of Oregon in a similar capacity, and also in the state of Illinois. So I've had experience in small, medium, and large states in a variety of challenges around the drug and alcohol issue. So I'm going to drill down a little bit more today on the Vermont Care Alliance for Opioid Addiction, colloquially known as the Hub and Spoke, and tell you a little bit about why we developed the model and what we're learning and some of the outcomes that we're seeing. I probably have more information than I'm going to have time to go through, but I'm happy to share anything with you. I am now retired, so I live in Chicago, so I will be giving you some information that is not totally current, but I think for this purpose it'll give you a good foundation. Where do I point this? Okay, there we go. Press it hard. So Vermont is a small rural state in New England, population 625,000. And I say this because we do things statewide in Vermont, and it is unique in that regard, and some of the larger states certainly don't have the same opportunities. But I think this model is very scalable to regional approaches. Let me talk a little bit about how we got started. Vermont actually was a state that was very late to any kind of medication-assisted treatment. When I arrived in 2004, there was only one methadone provider serving 100 patients in the whole state. And they were just beginning to experience a ramping up of the opioid challenge. No one was calling it a crisis yet. But it was increasing rapidly, and we were hearing about the inadequate treatment capacity. There was a great deal of stigma about allowing any kind of methadone treatment, very little buprenorphine when obviously things were just starting in that arena. The healthcare costs and the criminal activity related to these patients was high. Poor patient outcomes, they were in and out of emergency departments, et cetera. program silos were very challenging for people. The primary care physicians and the public addiction programs were not very well coordinated. And key providers were not participating in many ways at all with treatment. And the patients were feeling very isolated. You know, they did not have good health care. So that was what we call the perfect storm, and got us to start thinking. In Vermont, the Medicaid agency and the Alcohol and Drug Agency, mental health, corrections are all under one human services department. So the good news was we had an opportunity to actually try to do a more integrated approach, which is not always possible. So I will say it a couple times throughout my talk, leadership, I can't say enough that the leadership to make any of these changes is critical, and not just leadership in one arena, but political leadership, community leadership, medical leadership, recovery leadership, because you know, we're really rolling the rock up the hill. So going to the providers, we heard from the medical providers as we began to reach out to them to become waivered. You know, remember, Data 2000 had been passed, and so we started by doing a couple of things. Trying to get more methadone clinics approved, and trying to get more providers to become waivered. We heard the following views of barriers to expanding treatment. The primary care providers didn't think that they had enough time to spend with these patients. They were very challenging. They were too complex. They were afraid if they opened their practices that they'd have these people that they didn't really want sitting around their waiting room, and they were afraid of the demand overtaking their ability to respond. The OTPs, on the other hand, the methadone clinics, we ramped up a couple more. So in 2004, we now had 3 methadone clinics throughout the state. They were very isolated. They only offered methadone. They had a hard time recruiting workforce in the rural areas. And the healthcare system was skeptical about working with them. So it wasn't easier for them to develop partnerships. The attitudes about addiction, I mentioned there wasn't a lot of knowledge either about MAT, and here's where the research comes in, because at the state level we did a lot of work partnering with some of the folks from University of Vermont, whose names you saw, I think, in the previous talk, to educate the legislature, educate leadership in the medical community about the efficacy of medication-assisted treatment, one of the most studied treatments that we have, methadone, that is. And so we tried to address those attitudes about addiction and why these medications were so challenging. So that's the landscape when we started. And I'm not going to have time to go through all of the steps that we took. I will say, though, that Vermont was a leader in developing a health home model called the Blueprint for Health. And we built a lot on that health model that was initially used for diabetes, cardiac care, that relied on specialty expertise combined with community services and adjunct services for patients. So the hub and spoke is basically a systematic response. You've heard a little bit about this from Todd. The program enhances the provision of MAT by adding healthcare, the six health services that go along with it, which I'll get to in a minute. And it links the traditional treatment staff and the addiction treatment organizations with primary care practices and community health teams to provide evidence-based care. So it is a team-based model, and it relies on a team that contains people at various levels. It doesn't say so here, but I will just mention including peer recovery, and increasingly including more focus on peer recovery as the STR funds have come out. So the CARE Alliance is, and just give you the formal definitions. A hub is a regional opioid treatment center. It is a methadone clinic. We felt it was very important to have the hub contain all levels of expertise for MAT. Some states that I've gone to and talked with have said, well, could it just be a sort of a buprenorphine clinic? Well, it could, but what we found is that we had a lot of churning going on when we initially had physicians starting to ramp up their practices and serve people with buprenorphine treatment. And so for people who really weren't well suited for office-based treatment, they were coming in and out, they weren't sticking with treatment, they really needed the structure of an OTP, an opioid treatment program, which is what a methadone clinic does. And so there's oversight and there's a lot of checks and balances for the patient to make sure that they can manage their care and be successful. And at least in the beginning, for many of these folks who are coming from criminal justice, who have not had good health care, who don't have a lot of community support, we found that this hub with a high level of coordination was really key. So obviously patients who need methadone must be treated in a hub, and there are now 8 across the state in Vermont, and we systematically built up to that. They also treat people with buprenorphine, Vivitrol, any of the medications. So they have to be able to be a full service and also do all of the counseling required and adjunct services. So they are the specialty care, just like any other medical specialty. A spoke is a medical home, and often just a regular primary care practice, family practice, or a federally qualified health center. And they also coordinate care and the support services for their patients with opioid addictions. We say with less complex medical needs. Not always. There are some wonderful primary care physicians that do it all, and to be commended, especially in these rural areas. But depending on the patient's needs, support services are also critically important. So we encourage all of the partners in this effort to focus on the whole spectrum of needs that these patients may have. So particularly jobs, very important, how we're going to get them stabilized, and recovery supports. Again, we have a network of peer centers in Vermont around the state that provide recovery support, and we have made sure that those centers are linked to the hub and spoke so that we're really creating a whole network. Again, just to restate it in a different way, our goals when we started this were to improve access to addiction treatment, primary goal, integrate addiction treatment with healthcare, and improve outcomes for patients through the things that I've mentioned. We did use a bundled payment. The OTPs, the hubs, are paid a monthly rate. And if the patient gets just the traditional OTP service, they're paid at one rate. If they deliver the enhanced health home services, then they get a higher rate. That's to incentivize more comprehensive care. And I'm going to talk in a minute about the spoke teams. And I'll say a little bit about outcomes. I won't have time to get into that in detail, but I do have information in the slides if anyone would like those. They're welcome. So this is just a graphic way to look at it, primary care connected with the other services. The model that we started with, very briefly, we had 5 regional centers. We had 125 physicians prescribing buprenorphine. The hubs had 6 FTEs, RNs, and master's level counselors for 400 patients. Again, I can get into more detail if anyone has particular questions. The key factor is that we looked at, for every 100 patients that a practice had, physician practice, every 100 patients, either for a practice or a group of practices, the blueprint hired and assigned 2 FTEs to those practices. It was a nurse, case manager, and a master's clinician. So that is part of the Medicaid waiver. It's unique to Vermont. Those people may work for the hospital, they may work for a center in town, but it's all managed through that state Medicaid waiver. So that, I guess the key factor there is that it is an enhanced team, and how you're going to pay for that, billing or grants, is critical. And I know different systems have tackled that in different ways. I already talked about the rates, and that's just another way to look at that. The opportunity when we first developed this was under the Affordable Care Act. We did receive a 90-10 match for the first 8 quarters, which enabled us to get it jump-started. But it has been continued since then. That started in 2008. It's continued with state support and another Medicaid waiver that's rolled this into the business as usual. So why was that so easy to do? Well, it wasn't really all that easy, but I think data and research is really important. I want to make sure I try to tie this back to those of you who are actually doing research, because people want to know, does this work? I mean, this was not cheap. And I can give you dollar amounts if people are interested, but we had to show that this was making some kind of a difference. Not only were people getting treatment, but they were getting better, that we were getting different outcomes. So part of that was including the 6 health home services, which are listed here. That was part of the Affordable Care Act in order to get the enhanced funding. And so we were not only doing something different with the physicians, we were also doing something different with the traditional addiction treatment providers, expecting them now to become more familiar with the other kind of supportive healthcare services that these patients needed. And just to say that this is Dr. Brooklyn's slide, John Brooklyn, who was the medical director that was a driver behind this whole system. And he always insists that we talk about the MAT team being such a cornerstone, because without the team, most of the providers would really still be challenged to be able to do this. So again, I'll take a minute to just give kudos to Dr. Brooklyn, who single-handedly did so much to spread this around the state of Vermont and has done talks around the country. Dr. Stacy Sigmund, who's done a lot of the research on buprenorphine. So all of these team of people really are beneath this, and were so essential in making this happen. Martin asked me to make sure and talk about the training. What did we do to support the physicians? We actually developed a learning collaborative similar to the ECHO model with Dartmouth, with the Geisel School of Medicine, to work on developing common protocols, regional networks, training on a variety of topics from SBIRT to pain management, and it was really driven by the needs of the physicians and the partners. So it was an iterative kind of model where they would come together once a month or once a quarter in person. In the beginning, it was more frequent, and then monthly phone calls and follow-up. The ability to talk to an expert locally, frequently Dr. Brooklyn and some of the people he trained. Again, this is just the sessions, and I think it's still continuing. I'm not sure if in exactly the same way. There's been some changes in partnerships, but This was really a critical effort in getting the whole statewide system to be coordinated well together and to be using the same types of instruments. Dr. Brooklyn developed a tool for assessment and placement of patients, so we trained to that tool and continue to use that system to support. These are some of the topics that the partners had to look at as part of the collaborative. We measured these things, waiting list, retention in treatment, reducing diversion. These were all issues that we addressed in the collaborative. And again, I do have a curriculum. If people are interested, I can share that. A few of the learnings, again, I think we've touched on this, enhanced staffing. The practices stressed organizing the patient panel. You don't have these people coming in throughout the week. You pick Monday or Wednesday, and have the panel come in together and the clinic model so that it's easier for the practice to manage. Trying to reduce co-pays and the billing and all of these barriers for these patients, which is probably a whole talk in and of itself. The leadership, the physician champions. I can't say enough about the importance of physician champions because physicians want to hear from other physicians how to make this work. And so we intentionally developed physician champions that would be part of the team with Dr. Brooklyn and others. Our health commissioner at the time, Dr. Harry Chen, former emergency room physician, well regarded in the state. So, we really built on that leadership. Okay, so I'm not going to get into the outcomes. I'm going to just flip through them really quickly to show you that they're there, and people who want them, I can share the slides. I'm running out of time. We looked at changes in attitudes and behaviors, reduced use, improved access to care, lowering health costs, and improving patient functioning. Highlights, we did show a cost savings and other medical costs, and so that was good. That's published in the Journal of Substance Abuse Treatment. And I have one slide that just summarizes all these, so I'm going to flip through. We saw increased number, the blue line, people in treatment, decreased people waiting, increased number of spokes, and people in treatment in the spokes. Most importantly, we saw the rate of overdose deaths grow more slowly in Vermont than in the other New England states. So that we considered to be a marker of success. Dr. Richard Rawson, formerly of UCLA with the University of Vermont, did an evaluation. I have a paper, again, I can give people the link to it, but he did an evaluation with these objectives. And since I'm running out of time, I'm just going to flip through these. It was a patient sample with interviews. He looked at a number of areas of patient functioning and drug and alcohol use, patient satisfaction. And we see reduced drug use, changes in functioning, patients reporting better functioning, decrease in overdoses, criminal justice, decrease in illegal activity, and here we go. That's the summary. So this kind of data was very important to demonstrate to our legislature that this was a good investment, to demonstrate to the federal government and CMS with Medicaid that this model is promising and showing good outcomes, and will be continuing to be evaluated. I would also just close with saying that those of you who do community work, it's so critical to have community partnership between researchers, evaluators, and community practitioners, because all of the wonderful information that you glean from your studies when we try to put it into practice, people want to know, does it really work in the real world? So partnerships are critical, and I thank all of you for your commitment to helping us in the trenches with really making a difference. Thank you.
All right, so we'll take questions.
Hey, thank you very much. I'm Gavin Bard. I'm at Hennepin Healthcare, University of Minnesota. I have a question more about the hub and spoke model, and it's about the financial sustainability of it. So it's very clear that it lowers overall cost of care in terms of reduced utilization, et cetera. But unless you're part of an ACO, if you're in an organization that lives and dies by RVU generation, and you're getting only 35 cents on the dollar for Medicaid reimbursement, is it truly sustainable for the institutions that are doing it? Yes, it's sustainable for the state system because of the cost savings to the state, but in terms of being able to cover salary costs and FTE of the providers, is it a sustainable model?
Well, let me just say that my role as a state official was to look at the state system. So I think it was very important that we looked at this comprehensively, and I don't know another way to really look at it. I'm now back in Chicago, and I would say we're looking at the same thing. How do we work with our partners and look at networks and our treatment deserts to improve? But it's still going to involve having to partner and not just rely on one person doing something out there. So I think that the system is an important part of sustainability, and that's different in every state.
Yeah, I would completely agree and add that there is a disparity in the U.S. in terms of sustainability. The biggest driver of getting people into treatment is insurance. And in Medicaid expansion states, with accountable care organizations, there's greater odds of being able to achieve sustainability. The state targeted response, in part, interestingly, I think, is ending up trying to bridge that disparity in non-Medicaid expansion states, but that's going to last 2 years, and we need additional solutions in those states.
I would just say we're hoping some of this data actually helps Congress see that these models work, because it is important showing that on all levels.
And just very quickly, recognizing it really doesn't answer the question that the Medicaid funds by themselves are inadequate for maintaining maintaining programs. But like many systems, you take what money you can from some of the patients, and you have to have gradations of pay for others. And like many systems, you make up your money where you can. You try to get grants in other ways, and it's an issue of understanding that there are these are very underfunded systems. And so that's a part of what we have to bring back to the legislators is a sense of cost effectiveness, a sense of return on the dollar. When you see the decreases in the cost for the criminal justice system forever, those kinds of savings should be returned back to the treatment system so that the system can be more effective. So acknowledging that there are parts of this that don't work very well at all, but at the same time that the Medicaid expansion and the increase in the number of patients who have access to this care really is the major issue that we're trying to drive here now. The next message has to be, let's actually pay for it.
Hi, Jennifer McNeely from NYU School of Medicine. I'm just curious, as we all know that there is a very robust evidence base for the effectiveness of these treatments, methadone and buprenorphine, and really that if we can get treatment to patients, that they will do much better and have better outcomes. And yet I heard you speak to, in Vermont, the importance of patient-level outcomes data as driving support for this program in the legislature. So as researchers, can we focus really on the access question and now make the assumption that treatment works and we just need to get it to people? Or do we still need to continue to evaluate patient-level outcomes for policymakers?
Well, we probably all have a little different thought on that, but I would say legislators, my experience in states I've been in, legislators want to know if it's working in my state for my people. So I think it is still important to be able to demonstrate effectiveness for people, while at the same time using the information we have from the research to say, this is an evidence-based treatment, we're implementing it, and we know that it works. But I don't think we're totally to the point where everybody takes that for granted. A lot of people just aren't aware of the research, so that's been my experience.
I think it's important to continue to collect patient-level data, partly because the landscape in which people are using opioids is changing as well. So, for example, now fentanyl is much more, prevalent than it ever used to be, and we don't have a really good handle on what these, standard medications, like how effective they are in treating, fentanyl abuse, for example.
Hi, Sheila Vicaria, Drug Policy Alliance. I just wanted to respond to Mr. Long's comments that marijuana legalization is being done in efforts to pander to millennial voters. I think that one of the biggest drivers of health disparities among people is spending time behind bars, being denied opportunities for integration, such as public housing, financial support, financial aid for school, and also it drives health disparities between Black and brown people, particularly Black and brown men. And so I'd really like to push back against legalization not being related to health. And I'd like to at least ask that CPD consider, if legalization isn't part of our agenda, sealing and expunging records among people convicted of marijuana charges, along with other drug charges, can drive health and well-being and get people better integrated.
Andy Tompkins, now at UCSF, and I had two questions. One, how in the hub and spoke model, you mentioned having access to good mental health care, but I didn't see a psychiatrist or nurse practitioner prescriber. How did you get those persons integrated into the program and paid for? Because California's model of payment actually makes it almost impossible for psychiatrists within an OTP to charge and get reimbursed for their system. That's one question. The second question is, there's a big push now in California and maybe other states to get people started on MAT while they're in the hospital and the ER, and how would that integrate into a hub and spoke model, if you had any comments on that?
Okay, I think the model, and I didn't have it in the slide, but we have a fuller description of the staffing, and it does include psychiatrist time, not 100%, but that is an expectation that psychiatrist time be part of the mix, but also that the specialty clinics have relationships with mental health programs and so forth. So it isn't expected that they're going to do all of the mental health care that's needed, but that they have those connections so that patients have access to that as necessary. I would support that it's the payment, again, as has been said, is the challenge to make sure that all those costs can be reimbursed, and it's difficult as we pay for things now. Did you want to say something about second?
Sure. With regard to the second question of how hub and spoke might play out with hospital and ED initiation, that is a major issue, and One of the key components of hospital-based initiation of MAT is partnering with community prescribers. One solution that's coming up, in addition to just linking with willing primary care prescribers and OTPs in the community, is the opening of bridge clinics at some of the hospitals. For example, at BMC and Mass General and other places where the person has started on the buprenorphine in the emergency department and then given follow-up in the next couple of days at the bridge clinic where they can continue to dose, continue to be evaluated and stabilized as they transition into other practices. Sometimes that becomes continuous prescribing in that bridge clinic. But I think we're all looking at an opportunity to expand across the healthcare spectrum.
So I have a question for Martin. The other week, Mary Jean Creek showed me some data she pulled from the NSATS data set, looking at number of patients in program-based methadone and buprenorphine from 2015 to 2016, and there was a net loss of 25,000 patients across the United States. In the midst of an opioid epidemic, we're seeing the numbers of people in program-based treatment go down by 25,000. Do we know if there's been enough of a compensation of office-based enrollment to make up for that in the midst of an opioid epidemic?
We actually don't have any data on that, at least not that I'm aware of. If somebody has access to any of this information, we'd be more than happy to look at it. SAMHSA actually has, for whatever reason, not surveyed docs to even look at how they're making use of their waivers. There's no numbers for capacity whatsoever, so we don't know where the treatment shifted to. If you look at the, we do know, for example, that if you look at the models of care for other countries, that when buprenorphine was introduced, that there was a huge shift in those entering buprenorphine treatment, and that those numbers rose very rapidly. So we can assume that some of those numbers did shift over to the private practices, just from looking at what happened in other places. But SAMHSA actually hasn't been collecting data so far about how physicians are using their waivers, how many patients they're seeing, how long they're seeing them for, or anything along those lines, so at least not to date. Sid? Unless Sid I'm sure will contradict me entirely.
No, Sid Schnall, Pinney Associates. Actually, we are collecting some of those data through IQVIA data. And although there are more waivered physicians, as you've described, they are not reaching their limits at all. And there really is a very small number of those who have the waiver who are actually prescribing at all, which is a big problem. And I think back, Everett Koop once made a statement that we shouldn't make the treatment harder to get than what's causing the disease. And I think we have a big problem here. And although what you have been describing is certainly moving us in the right direction by making treatment more available, we still have barriers that really, anybody can go out in the street corner and buy drugs these days. They're very available. For a physician to prescribe opioids, they have to fill out a form and send it to the DEA and pay their, I don't know, $300 or whatever it is today, I don't remember. But to prescribe buprenorphine, you gotta be waivered, you gotta take a course, gotta do some things, methadone clinics, we have all sorts of regulations. We have made the treatment harder to get than the products causing the disease. And if we really want to be effective in treating the problem, we have to make the treatment readily accessible. And we're moving in the right direction by moving it more into primary care. But I think we still have a long way to go. And by removing some of these barriers to providing treatment will also result in removing some of the stigma. I think these barriers only tend to enhance the stigma.
I agree. Thanks, Sid. Last question, Mark?
Yeah, an observation and a question. So I wonder to what extent the experience in Vermont is generalizable because it's such a small state. The VA, there are a lot of services in the very rural areas, specialty services that are just really hard to get because the places are under-resourced. And so it's hard to find someone who can prescribe clozapine or lithium or an ophthalmologist. I mean, that's just the nature of living in a sparsely populated area. And so the VA solution has mostly been, or a large part of it has been clinical video teleconferencing. Just the idea of training, because, you know, we're looking from an MAT perspective, but for these rural providers, they have to figure out how to provide all sorts of different specialty cares. And so saying, we'll set up something particularly for MAT, you know, if they don't already have an infrastructure for a variety of specialty care, that's difficult, and it's kind of a one-off. So the question is, what role do you see for clinical video teleconferencing in getting MAT to these far-flung areas?
Todd?
Yeah, I think I would agree with your point, and I think that partnerships and telemedicine and, you know, all of these things have to come into play, because it's very true in a remote area, they struggle with everything. And so I think that as we bring more of the addictions knowledge into general medicine, it helps address the issue you're raising, but it also helps in other ways. So I think people knowing how to work together more as a team and using, you know, telemedicine and other partnerships is going to be essential for whatever the issue.
I'm going to cut off the discussion now because we've run a little bit over, and I want to thank the audience for being here, and I want to thank our panel of speakers as well as the forum.